When I arrived in Buenos Aires, I was asked to give a talk to especially the younger doctors there. And instead of a specific talk that I give very often on testicular cancer or lung cancer, I decided to do a different type of lecture talking about innovation. And the idea of innovation is that when you are a young doctor and you decide to go into medicine, and then you decide to specialize in treatment of malignant diseases in oncology, the majority of doctors are brilliant in order to get into medical school. They're also brilliant in order to get a fellowship at a program that can give them training to become a hematologist or an oncologist. So there's not a lack of intelligence. What we try to teach in our fellowship program is several things. Number one is empathy and compassion. So anyone can look in a textbook, look in guidelines as to how to treat a patient, look at signs and symptoms. And because we are in a computer age, we've lost a lot of the doctor-patient relationship. Instead of looking the patient in the eyes, going over what the plan of attack is going to be, and showing compassion and empathy, there's a tendency to turn your back on the patient and look in a computer screen and just type out a note. And in the United States, because billing is dependent upon the length of your note, that's a good part of what we do in the United States, which is very different than in South America, where that's not an issue. But empathy and compassion is something that is hard to teach. You have to really have that in your heart in order for that to be successful. And that's part of being a successful oncologist. But you can be a brilliant oncologist, pass your boards, get very high scores, and do whatever the guidebooks tell you to do. And you're going to be a fine doctor, you're going to find great satisfaction in your job, and your patients are going to be very appreciative of what you have to offer. But far different is innovation. And by innovation, meaning doing something new and novel rather than doing something that you were taught 5, 10, 15 years ago. And there's no field in medicine where innovation is as important as it is in oncology. There are new treatments in all diseases in medicine, not just oncology, but the wealth of information that has come about, knowing about the biology of the disease, knowing about malignant target, molecular targeted agents, that we can see the underpinnings of what makes a normal cell a cancer cell and use that information and devise logical clinical trials with novel agents. And immunotherapy has just exploded in this field. And I have been advisors in the past to some of the major drug companies worldwide. And 15 years ago, no pharmaceutical company had on their board the idea of any type of immunotherapy or molecular targeted agents. They were all developing the same old chemotherapy drug A, chemotherapy drug B, trying to put them into some type of combination and show a 2-month improvement in survival and present a paper at the meeting. And that may be great for the company and may be great for someone's CV, but it's not great to move the field forward. So innovation is developing something either from someone else's laboratory work or your laboratory work, finding something that makes sense and bringing it to a clinical trial and trying to prove that it is better than standard therapy. And all one has to do is look at the national and international meetings, and there's innovation all the time. We're not smart enough to know what innovation is going to be better, worse, or the same as the standard therapy. But if we want to have improvement for the current status quo, we need to innovate rather than doing the same therapy. Now, fortunately, there are, at least in my institution and most institutions worldwide, what we call institutional review boards. You don't want to have some maverick who has done something that is dangerous. There's a lot of cancer quackery out there. There's a lot of, the internet is replete with things that have no value at all, but are picked up by patients and sometimes can be picked up by doctors as well. So we have this wonderful depth of knowledge that we have as far as the immune system and as far as molecular targeted agents. And the field is wide open for any young doctor to develop a new therapy that they can call their own and take pride that this is now the standard therapy. But a cautionary note, we hope that standard therapy will not be the standard therapy 10 years later. because unless we're getting close to 100% cure rate in the disease, we're not going to be satisfied with moving the needle from a 20% cure rate to a 25% cure rate, which is significant and meaningful, but again, not the ultimate goal. So this is what we mean when we're talking about innovation. Now, the bad news about innovation, as investigators know, it's expensive. When I was working with platinum and testis cancer, clinical trials were very inexpensive. We had one data manager, we had one nurse, and we had myself. We were able to get the drugs free from the National Cancer Institute in the United States. It's very different now. So most of these new agents come not from the universities anymore. They come from big pharma or little pharma or various types of companies. So we have a partnership with the investigator who has a clinical trial idea, but going to the drug companies so they can get these novel agents and get support for doing these clinical trials. I wish innovation were less expensive. And one of the things I mentioned as far as the companies are concerned, when we look at immunotherapy in lung cancer, which is another disease that I specialize in, as well as testicular cancer, immunotherapy has absolutely transformed how we treat lung cancer, and almost all patients with all stages of lung cancer, with few exceptions, are going to have immunotherapy as part of their treatment. It used to be in lung cancer that if you had metastatic lung cancer with liver or bone or brain or adrenal metastases, the 5-year survival was 1 or 2%, and that's chemotherapy era. Now it's about 25%. We wish it were higher, but it's 25% rather than 1 or 2%. That's the good news. The bad news is the financial cost of these drugs in the United States. So to get 1 year of immunotherapy with or without chemotherapy, it's about 200,000 US dollars, and I can't quite translate that to Argentina pesos, but I think you get the idea. And it's even worse because we don't stop at 1 year of immunotherapy. We give a minimum of 2 years unless someone has progression or has irreversible toxicity with grade 3 or grade 4 toxicity from the immunotherapy. So it's very expensive. And in the United States, we have one drug that is a novel agent, and then another drug company has the same type of drug with a different name, a third company, the same drug, a fourth company with the same drug. They're all priced the same. It's only when the drug becomes generic that the price goes way down, as happened in the chemotherapy era. So you should congratulate yourself for choosing the field of hematology oncology. There is no more satisfying job, both philosophically, scientifically, medically, and socially, than what we do as oncologists. And you're going to do a great job as oncologists. You're going to have great training, but you have to have in your heart compassion and empathy for the patients, and you have to have in your mind, do I want to try to do innovative things, or do I want to take what I learned from my fellowship and wait for someone else to make the innovation?